Welcome to the CHEST Clinical Guidelines podcast, where we transform complex clinical guidelines into compelling, real-world narratives. I'm your host. My name is Lisa Moores. I'm a pulmonary and critical care physician, and I practice at the Uniformed Services University. I'm thrilled today to be joined by two authors of our recent CHEST guidelines on the management of early-stage non-small cell lung cancer. We have Dr. John Howington, who's a thoracic surgeon just outside of Seattle, and Dr. Natasha Leighl, who is an oncologist in Ontario and deals primarily with patients with primary lung cancer. And I am very excited to have them both here to help those of us who don't spend all of our time in lung cancer understand the impact of these new guidelines. So as someone who is not a thoracic oncology specialist, my job today is going to be the voice of the audience and the curious clinician, and to draw out your expertise to help us understand what these patients are facing and how the CHEST guidelines might help you navigate their care. Dr. Leighl, you were going to share a case with us that you've recently managed?
Yes, thank you so much. So I recently had a patient who met with me. She was a lady in her early 60s. She's of Asian ancestry, a lifetime non-smoker. This is a story that we now often hear in our lung cancer clinics. And she didn't have lung cancer screening because she doesn't qualify, but she had an abnormal x-ray with her family doctor. And I think the family doctor had a lung cancer scare in his practice and was doing some x-rays on different patients. Now, this patient, she had a 3 centimeter nodule on her x-ray. And so she went on to have further imaging and eventually went on to have surgery for a diagnosis of lung cancer and came to see me afterwards.
It's interesting you say, we wouldn't normally do screening in this area. I'm curious because I feel like I'm hearing that this is happening more and more, especially as we see more lung cancer in non-smokers. I don't know if this is true, but it seems like more so in the Asian population as well, that there may be some heightened awareness, particularly if there's a family history of lung cancer. So um, that didn't sound all that strange to me that somehow she ended up with a chest X-ray.
I couldn't agree more. I think one of the great things about lung cancer now is that we have screening, but particularly in North America, it's really limited to patients with tobacco exposure. We have learned from colleagues in Taiwan that, just as you said, patients with family histories can also be at significant risk, and in particular, women. And non-smokers, we can find quite a high rate of lung cancer if these patients, especially with a family history of lung cancer, undergo screening. And so I think we will see this world evolve to better match what we end up seeing in clinical practice.
Interesting. So what were your initial conversations like with this wonderful woman?
So I actually got to meet her after her surgery. She had a resection, she had a VATS right up her lobectomy, and she was found to have a 3.1 centimeter lung adenocarcinoma. And we routinely do molecular testing on lung cancers in Canada, irrespective of stage. It's reflex, it just happens. And they got back the report that she had an EGFR mutation. And the surgeon called and asked for her to see us. And so, I find it's very interesting. It really, in North America, it's really the surgeon who's the gatekeeper to what comes next. If the surgeon says, I got it all, you don't need anything else, even though the patient's referred to you, they'll come to you and they'll say, oh, no, 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 I don't need anything else. The surgeon explained, they got it all, we're done. But if the surgeon says, "Oh, look, I want you to go see the oncologist about targeted therapy or chemotherapy or something else," then the patients will often come looking for that or, a trial or, something with a new mRNA vaccine. They'll often come and tell me what they're there for. So she, I think she was still quite stunned having had a diagnosis of lung cancer. She was stunned to come and see a medical oncologist. She'd done a little bit of Googling, but not too much. And so she was pretty overwhelmed and just said, here she was. She'd been told her lung cancer had been removed, and now what? What did we want with her now after she'd been through this whole process?
I'm curious, John, is that your practice too, to get the surgical information before you decide whether you need to bring in the medical oncologist or the radiation oncologist or other colleagues, or is that a discussion you sometimes have prior to any operative procedure?
Well, it's clinically stage specific. So in a patient with a 3 centimeter nodules can be 1A3 or 1A2. Many of those will have been diagnosed and staged by our interventional pulmonary colleagues. And so they're a clinical stage 1A. We would not necessarily review those up front, but at the time of surgical resection, we do at least 3 mediastinal stations and at least 1 Howard station, but do a systematic lobe specific node dissection so that we get the information about what is their pathologic stage, and that informs the conversation. And Natasha's correct. I tell patients, I can tell you all you need to know about surgery, but I'm going to let the physician that provides care to patients, either targeted therapy or systemic chemotherapy, and follows those patients, to inform you in that. I'm not copying out of the discussion. I tell my children all the time, speak to what you know. So I speak to what I know. And I know that if someone has a stage 1B or higher, and they've got a mutation-driven lung cancer, they should see the medical oncologist.
So what did that conversation go like? I can imagine her being overwhelmed. I'm thinking about not knowing as much about targeted therapy and the side effects. I imagine as a patient thinking, all right, well, what's the real outcome that I'm looking for? Is this going to impact my long-term survival, or is this just going to impact some short-term recurrence? And how am I going to feel while I'm on this medication? How is this going to impact, my daily life? I'm thinking those might be some of the things, but, patients come in with all kinds of worries that sometimes they say and sometimes we have to pull out of them, I think.
You're absolutely right, and I think that, especially in that initial meeting, it's so important to really get a sense of what's important to people so that, we can talk about their care and I can make sure that they feel really supported to make a decision that's right for them. So, her first concern was, she's in a medical oncology clinic at the Princess Margaret Cancer Center. Were we gonna talk to her about chemo? And because the tumor was smaller, less than 4 centimeters, the answer was, good news is we're not gonna talk about chemo as prevention. I find using the P word, prevention, really, really helpful for patients. Then they sort of enter that same world as our breast cancer patients and colon cancer patients are in. They know that the surgeon's done a great job, very high chance of cure, and these extra medicines are really to increase that chance. I think that's really helpful for patients to know. So for her, it was about targeted therapy. We recommended a third generation kinase inhibitor, osimertinib, for up to 3 years. And, she's a teacher. She wanted to know, should I stop working? I've had time off to recover from the surgery. Am I safe to go back? Is my immune system okay? What about stress? Will that increase my risk of cancer coming back? And then also, she'd been thinking about retiring. How would this impact that? Could she take these pills and travel? Did she need to stay home? What were the side effects? And we say they're usually very well managed. For some people, some dry skin and some rash. For some people, some diarrhea, usually well controlled with Imodium or other medications. But of course, some people always have a little bit more. So, for her, I think she was reassured. She was very keen to try the treatment, which we have tried, and she's actually done quite well. She ended up retiring. She and her husband talked it over, and they just thought, you know what, just a few more years, may as well just go ahead and retire and travel now, and enjoy the things that they've always wanted to do. And so that's been really great about targeted therapy was that patients can often travel, and they have more freedom than we used to in the old days of chemotherapy alone.
Sure. This could be for either one of you. This sounds like obviously a very early stage lung cancer with a complete resection. I've peripherally followed all of the science behind the mutations and the targeted therapies. Is this recommendation in the current guideline, is this new? Like, are we moving back into earlier stages? Certainly in my early training, as you said, Natasha, that we would have been done, right? It's a small tumor. We got complete resection, which I would think would be comforting to patients. Maybe not all, but knowing that there are additional things they can do to potentially impact the long-term outcome.
So, John, do you wanna take that first? I think from a surgical perspective, right, it must be incredibly exciting. We're excited in medical oncology, but it must be great also for surgeons.
Yes. And so, Today would be a stage 1B tumor, as was mentioned, because it's over 3 centimeters. And that was kind of the gray area. And we didn't, with systemic chemotherapy, have great, overall impact in survival. And when you're trying to balance that with potential toxicity, it was challenging to suggest that to all the patients and be confident about who was going to benefit. Now, with this prospective randomized trials, we know those patients significantly benefit from targeted therapy. And this is something specifically directed towards the cancer, mutation in the cancer. And one of the terms that's used in our field is mutation addicted or mutation driven cancers. And so if you target that, you can be quite impactful on the circulating tumor cells and less impactful on the patient. Now, I ask Natasha to, if a patient has tolerated this drug for, say, 3 months and you're going to plan to give it for 3 years, if patients have tolerated well in that first 3 to 6 months, they typically do well with it throughout the course.
So it's been great that, especially with these EGFR inhibitors, patients have, sometimes they might get skin toxicity here and there, but usually most things come up within that first few months and patients learn how to handle them. That is a little different than immunotherapy, where I find that while most toxicities do occur early on, we can see these sort of dose-dependent toxicities over time. I will say that probably the one thing that we need to be mindful of as medical oncologists, and maybe we don't think about it enough, is these drugs can have very low risk of other toxicities, things like heart toxicity. Sometimes we can see decreased ejection fraction. So we do need to be mindful of those things and measuring. And I find, my colleagues who treat breast cancer are much more thoughtful about that, for example, than I am, where, it's so uncommon. But for the part, these patients do well. A few low risk things that we need to be mindful of, such as the cardiac impact. But otherwise, yeah, if you're good in the first 3 months, you'll be good for most of the next 3 years. Yeah.
This is fun, and for me, in that it sounds like the good news story, which I certainly have seen in lung cancer care. It doesn't feel like such a threatening, ominous diagnosis as it used to. And how much of that impact is because of screening versus, I truly believe more so our understanding and being able to personalize how we can approach the care of our patients. But it's exciting, and to know that there are things that we can do that will truly impact that long-term survival. Was there anything else that she brought to you that was maybe surprising to you, Dr. Leal?
I think what I've always been impressed with in people that go through this journey is that resilience. They've been through all of this. They've been told they have cancer. They're willing to have their preventive therapy, but they just get right back in there. The fact that she did get on with things, she is traveling, she is doing the things that she wants to do. I think that's so important that patients really focus on those aspects of their own quality of life and their survivorship. I also really love that she keeps in touch. She lets us know how she's feeling, what is working, what isn't working. And I love the school teacher in her. She's never shy about educating us or the team or telling us what went well and what didn't, which is so valuable to me, because then I can make the experience better for the next person.
And I suppose maybe one last question on this case, and maybe is one that she asked. Does this change what perhaps if she has siblings, what they might want to be asking, or if she has children? Is you think about breast cancer and women who are diagnosed, obviously men as well, but oftentimes women and their female children coming and saying, "Well, how does this impact me? And when should I think about screening?" And is that what we're seeing in the lung cancer field as well?
Thanks. So I think sadly we're not there yet. We should be, and I'm hoping in the next 5 years we'll have better advice to offer families. There's no question that if you have a first degree relative with lung cancer, whether you've had tobacco exposure or they have had or not, you do have an increased risk of lung cancer, obviously lower overall in people who don't have tobacco exposure. Um, There are a number of screening programs, and in particular in North America, I think a lot of them are still in research, where if you have a family member or even if you came to the clinic with somebody with a diagnosis of lung cancer, you might be eligible to participate in screening. So right now, my non-evidence-based advice for my patients' families is, let your family doctor know. Look, the doctor said there's no formal screening, but my mom got lung cancer at this age, and the doctor wanted you to know. And then, I always encourage them to stay, with it. So many of these great advances are on the news before they're even in the New England Journal. So, we hear about a lot of things very quickly, but I really encourage people to stay on top of that and just to be aware of what's out there. I don't recommend formal screening unless patients are able to get into something where they could, compute their familial risk and that kind of thing. But it'd be interesting to hear, John, at your center, if there are some more formal programs for family members.
So there's not currently, as you mentioned. So my comments would be, one, if you have lungs, you can get lung cancer. And in the United States for the last several years, more women have developed lung cancer than men. And that trend's not going to go away anytime soon. So, for the audience to know that lung cancer is a woman's disease. It's not a man's disease anymore. And that if you have symptoms, even if you don't fit the typical criteria, so you don't smoke, but if you've got a cough that doesn't go away, and particularly if you ever cough up blood, but most women would present to the doctor if that occurred. But if you have this cough that just won't go away, seek medical attention and advocate for yourself. I know I didn't smoke, but I've got something going on in my lungs. Can we look deeper?
Awesome. Well, thank you both for sharing that case with us and for helping educate me and the audience about how things are changing in early lung cancer. I found that incredibly educational and exciting about where we're headed. And I am really looking forward to talking to you both again about additional patients in this area.
Thank you, Lisa. It's always a pleasure to chat with you. And it's always fun and exciting for me to share what I know and my passion about lung cancer. Very appreciative to have been here today. Thank you.
Thank you.
Thanks. And I feel the same. It's been such a treat to be here and be part of this conversation. Hope to talk to you again soon.
I'm looking forward to it. And to our audience, thank you for joining us, and we hope you join us again on our next edition.